Good morning, my dear students. Hope everyone is ready to hear this new class. Till now, we have completed around 10 different topics in this specialty, respiratory medicine. I hope every one of you have gone through your textbooks about these topics, revising them. Make it a habit that whenever any topic is completed, you go through your books, standard textbooks on the same day. That will give you a clear edge from others, and that will give you a long-term memory, highly beneficial to you. Today, we'll go through two different topics. One, the occupational lung disease. The second one is the pulmonary fibrosis. We'll start with occupational lung disease. Occupational lung disease, also known as pneumoconiosis, they are the group of pulmonary diseases that are caused by the exposure to mineral dust by means of inhalation that occurs in the workplace. These specific types of pneumoconiosis are named by the substance that is inhaled. For example, if the patient inhales silica dust, sand dust, it is known as silicosis. And if the person inhales asbestosis, asbestos dust, if the person inhales, that is known as asbestosis. And if the person inhales coal dust, that inhalation is termed as coal workers pneumoconiosis, otherwise known as anthracosis. There are other different types of occupational lung diseases like hypersensitivity pneumonitis or farmer's lung that occurs in the persons who are working in agricultural fields. We'll discuss about that aspect later. So the three main mineral dust induced lung diseases are coal workers pneumoconiosis, where the exposure is to the coal dust. That can be simple coal workers pneumoconiosis, where there will be accumulation of the pulmonary vacuoles and nodules in the lung parenchyma. In some patients, the coal workers pneumoconiosis gets complicated, and that develops into progressive massive fibrosis, PMF. And in occupations like sandblasting, quarrying, mining, stone cutting, foundry work, and ceramic tiles laying, in all these occupations, the person will be exposed to a lot of silica. Silica dust exposure is known as silicosis. And when the person is exposed to asbestos dust, in occupations like mining, milling, fabrication of ores and materials, installation, as well as in the removal of insulation, the persons get asbestosis. Here, asbestosis manifests in pleural disorders like pleural effusions, pleural thickening, pleural plaques, and there will be diffuse parenchymal lung fibrosis along with a dreaded pleural-based malignancy, the mesothelioma, as well as the carcinoma of the lung and larynx. Pneumoconiosis previously used to be called as occupational lung disease on the whole, but now the term is restricted to mean the patients who are exposed to coal dust. Pneumoconiosis at present is equivalent to coal dust inhalation. Coal workers. pneumoconiosis. And going to pathogenesis, the development of pneumoconiosis is based on the amount of the dust that is retained in the lung and the amount of the dust that is also retained in the airways, the bronchi. It depends on the shape, size, and buoyancy of the particles, as well as the solubility and physiochemical reactivity of the particles that causes the problem. If the patient's lungs are already affected by the concomitant tobacco smoke, this will cause additional effect on the lung. About the size, shape, and buoyancy of the particles which are more dangerous, they ranges in size between 1 to 5 microns in diameter, and because of this small size, they reach the internal bronchioles as well as in the alveoli, and they settle in the linings of their airway walls. About the solubility and cytotoxicity of the particle, these modify the nature of the pulmonary response. If it happens that the particle size is very small, then they tend to cause acute lung injury. And if the particles are larger in size, they resist dissolution, and so they may persist in the lung parenchyma for many years. And thus they evoke fibrosing collagenous pneumoconiosis in the long term. About the pulmonary alveolar macrophage, this is the key cellular element in initiation as well as in perpetuation of the lung injury and fibrosis. The more reactive particles that trigger the macrophages, and once the macrophages are triggered, they release a number of products that mediate an inflammatory response, and because of this inflammation, fibroblast proliferation and collagen deposition happens. Coming to the cold workers pneumoconiosis. Cold workers pneumoconiosis is because of the inhalation of coal dust, the carbon particles. It is associated with coal mining industry, where if the person supposedly if is exposed to both carbon and silica, that exposure is known as anthroposilicosis. There are a spectrum of lung findings in coal workers. They are very wide and they vary from patients being asymptomatic, called asymptomatic anthroposis. Patients can have simple cold workers pneumoconiosis, where the patient will be having minimal symptoms, but there not be any pulmonary dysfunction. And patients in complicated cold workers pneumoconiosis, they'll be having progressive massive fibrosis, PMF. We'll discuss about this now. About the simple capillaries, there are 3 different categories. Patient might be having few small rounded patches on the chest X-ray. That is category 1. In category 2, the small rounded patches will be numerous in number, but still the lung markings are clearly visible. In category 3, the small rounded patches are very numerous and all the lung markings are clearly obscured. About the simple cold workers pneumoconiosis, patient will be having cold macules. They range from 1 to 2 millimeters in diameter, and they consist of peribronchial carbon-laden macrophages and a dilated terminal bronchiole. The coal nodules are somewhat larger in size. They measure more than 4 millimeters in size. They are larger and fibrotic. They contain small amounts of delicate network of collagen, which is located primarily adjacent to the respiratory bronchioles. Microscopically, the carbon-laden macrophages and delicate collagen fibers, they collect adjacent to the respiratory bronchioles initially, and later they accumulate in the interstitium and in the alveoli. The dilatation of the respiratory bronchioles happens, which causes focal dust emphysema. Radiographically, these simple co-worker pneumoconiasis will be visible as bilateral small parenchymal nodules which are targeting the upper lung fields. So the nodules which are present in the upper lung field, they are seen in patients of simple co-workers pneumoconiosis. Patients with complicated co-workers pneumoconiosis, they'll be having dross changes in the lung parenchyma with multiple round fibrotic mass lesions with a central cavitation measuring more than 2 centimeters. They'll be mostly situated in the upper lobes of the lung. Microscopically, there will be dense collagen and carbon pigment present in the lesion with a central necrosis. The progression of the lesion does not correlate with the amount of the coal dust deposited. That is, if the patient is further exposed to the coal dust, that doesn't mean the patient will be having higher defect, or if the patient is taken out of the coal dust area, still once the complication has started, the progression of the disease will be going on. So the progression does not correlate with the amount of dust deposited further. Cigarette smoking increases the rate of the deterioration of the pulmonary function. Coming to the Kaplan syndrome. This is a syndrome first observed in the patients of co-workers pneumoconiosis. Later, this is found in other types of occupational lung disease. Here, there is a factor which is promoting the fibrogen, the fibrogenic promoting factor, which is accumulated in the lung parenchyma because of the immunopathologic mechanism. This happens in patients of rheumatoid arthritis, wherein the rheumatoid nodules called the Kaplan's nodules are accumulated in the lung parenchyma. So the combination of patients of rheumatoid arthritis who will be also suffering with pneumoconiosis, this combination put together is called Kaplan syndrome. A Kaplan's nodule is a large fibrotic nodule with a central necrosis which is surrounded by fibroblasts, monocytes, and collagen. So remember, whenever a patient of rheumatoid arthritis complains of having lung symptoms, try to exclude Kaplan syndrome. About the clinical course of this disease, usually the patients remain asymptomatic with little decrease in lung function. The dyspnea will be progressive and patient can have cough with expectoration. Subsequently, the pulmonary functions fail and there will be pulmonary dysfunction with restriction and obstruction. Both will be present in the patient. Later, the patient develops pulmonary arterial hypertension and right heart failure, carpal Now the disease remains progressive even though further exposure to the dust is prevented. There will be presence of chronic bronchitis and emphysema increasingly in these patients, but there is no association of this disease with tuberculosis and bronchogenic carcinoma. Coming to the treatment aspect, there is no specific treatment for this disease. Removal from further exposure to the coal dust is important, and the underlying airway diseases have to be treated adequately. Coming to the second type of occupational disease, it is silicosis. Silica is silicon dioxide. It's an oxide of silicon with a chemical formula SiO2. Silica is the most abundant mineral on earth. It's also known as grinder's disease and potter's rot. It's a form of occupational disease which is caused by the inhalation of crystalline silica dust, and it is marked by inflammation and scarring, which appears in the form of nodular lesions in the upper lobes of the lung. Silica is found in sand. Many rocks such as granite, sandstone, flint, slate, some coal and metallic ores contain silica. The activities like cutting, breaking, crushing, drilling, grinding, and abrasive blasting, all these activities cause the production of fine silica dust. So the works like foundry work, stone cutting, tunnel construction, sand blasting lead to silicosis. The diseases which are associated with exposure to silica dust are: one, silicosis. Silicosis might be chronic, or it might be accelerated or acute. Chronic silicosis, accelerated silicosis, and acute silicosis. In acute silicosis, the person is exposed to fine dust, and the exposure will be intense to high silica dust. Finally, this leads to progressive massive fibrosis, which goes on progressing on itself, by itself. And the second one is chronic obstructive pulmonary disease, which has emphysema and chronic bronchitis. There are also mineral dust induced small airway diseases also occur in this disease. Diseases like lung cancer, mycobacterial infection, immune-related diseases like progressive systemic sclerosis, rheumatoid arthritis, SLE, systemic lupus erythematosus, and chronic renal disease also can get the disease. There are three types of silicosis. One, simple chronic silicosis. It's the most common type. It occurs in the persons who are exposed to silica on a long term, that is, a period ranging between 10 to 20 years. This exposure will lead to a low amounts of silica dust. There will be nodules which are formed by the chronic inflammation and scarring in the lung and chest lymph nodes. Patients often remain asymptomatic and seen for other reasons. About the second variety, the accelerated silicosis, it progresses to progressive massive fibrosis. This defect occurs in persons who are exposed to larger amounts of silica over a shorter period of time, the period ranging between 5 to 10 years. There will be inflammation, scarring, and symptoms progress faster in the accelerated silicosis. Patient having dyspnea as the primary symptom. About the acute silicosis, it occurs from the short-term exposure to a very large amounts of fine silica dust. The lungs become very inflamed and there will be severe dyspnea and a reduction in the blood oxygen levels. The saturation, oxygen saturation falls in these patients. An example of acute silicosis, it occurred in early 1930s where in the construction of a tunnel called Hawks Nest Tunnel. This occurred in West Virginia, USA, where hundreds of workers died because of the acute silicosis. About the clinical feature, the main symptom is breathlessness. It's first noted during exertion and later it prevails at rest as the large working reserve of the lung is diminished. A patient with chronic silicosis presents without symptoms, without any pulmonary symptom, but he is assessed for the presence of some abnormality on the chest X-ray. The presence of cough with expectoration are common symptoms and usually they are related to the chronic bronchitis. Clubbing is not a feature of silicosis. Patients with silicosis are particularly susceptible to tuberculosis. This combination is known as silicotuberculosis. This has to be remembered. The reason for the increase is the increased risk of 10 to 30 times of the normal. The reason is not well understood. It is thought that silica damages the pulmonary macrophages. And usually these are the cell pulmonary macrophages which kills the mycobacteria. They have the ability to do that. And once the pulmonary macrophages are damaged, the mycobacteria will not be inhibited. About the diagnosis of silicosis, in general, three key elements are important. One, a proper and detailed history of the silica exposure. Is it sufficient to cause the degree of illness and the appropriate latency period from the time of first exposure to the silica to the present status that has to be noted. Second, chest imaging. Usually, a conventional chest X-ray is sufficient. It shows opacities that are consistent with silicosis and the presence of axial calcification. This is vital. The presence of axial calcification appearing as thin streaks of calcification on hilar lymph nodes bilaterally. This signifies that patient lungs are affected by silica dust. Third, we have to exclude other diagnosis. The absence of another diagnosis most likely to be responsible for the observed abnormalities have to be checked. So the presence of axial calcification on the hilar lymph nodes bilaterally, it almost exclusively occurs in silicosis. Coming to the treatment, silicosis is an irreversible condition and there is no cure. Treatment options currently focus on alleviating the symptoms and preventing further complications. The disease will generally progress even without further exposure, but the rate of deterioration can be controlled. Treatment of all forms of silicosis should be evaluated for control of coexisting mycobacterial infection. For this, bronchi or lung lavage might be required, and few patients need pulmonary transplantation, lung transplantation. Prevention is the key for this disease. Here, one point we have to note between the two pneumoconiosis, one cold dust and second silica. If a person is exposed to 3 grams of silica dust, the end result will be the patient might be losing his life. That is the severity of the silica dust. Same thing, if the patient is exposed to 30 grams, 10 times higher, 30 grams of coal dust, still the patient will be healthy. So that is the seriousness of the silica dust compared to the other agent. Coming to the third type of occupational lung disease, asbestosis. Here, there will be pulmonary parenchymal fibrosis mostly occurring in the lung bases, whereas coal workers and silica causes the defects in the lung apices. The upper lobes of the lung are targeted in both the other diseases. But here in asbestosis, the lung bases, the lower lobes of the lungs are targeted by this inflammation. Generally, this occurs when there is more than 10 years of exposure, but the latency period can be as high as 30 years, more than 30 years. Smoking has a synergistic effect with asbestosis in curtailing the function of the lung and also in the development of lung cancer. Clinically, asbestosis is indistinguishable from an interstitial lung disease, the IPF, Idiopathic Pulmonary Fibrosis. We'll be discussing about this now in this class. Asbestosis is associated with lung cancers, namely squamous cell and adenocarcinoma, but asbestosis doesn't cause small cell carcinoma or large cell carcinoma. Asbestos is a fibrous hydrated magnesium silicate. It consists of more than 3,000 commercial uses, and because it is indestructible in its nature and there is fire resistance and spinnability. Fireproof textiles as insulation for boilers and pipes. Asbestos is also used in paper, paints, clothes, tapes, filters, and in wire insulation. More recently, asbestos is also being used in the manufacture of cement pipes and friction materials, including brake linings and roofing and floor products. There are 3 types of asbestos. One, chrysotile, the most common. It forms the 90% of the total. It is the softest type and it is less fibrogenic. It doesn't cause serious problems. But procidolite is a blue asbestos. It's resistant to chemical destruction and it is responsible for the serious problem, the asbestosis and mesothelioma. Third variety, least commonly used, is the amosite. It's the least common variety, forms around 4% of usage. Clinical manifestation, asbestosis presents as pleural plaque. It is the most common type, where there will be focal, irregular, raised white lesions appearing on the parietal pleura. Pleura has 2 layers of pleura, parietal pleura and visceral pleura. Usually, pleural plaque targets the parietal pleura, and rarely it also might involve the visceral pleura. Commonly, the clinical manifestation occur in the lateral and posterior mid-lung zones where they will follow the rib contours and the diaphragm. Histologically, there will be paucity of cells and extensive collagen fibrils arranged in the basket weave pattern and a thin covering of mesothelial cells. Usually, the lesion will be bilateral and they remain stable over months. There is no particular treatment for the pleural plaque. Periodical observation and periodic chest X-ray are vital. Second variety is the diffuse pleural thickening. Here, the pleura appears as a white peel that can encase the significant pulmonary structures. The diffuse pleural thickening or pleural fibrosis is a disease that encounters the visceral pleura. So previously, the pleural plaque, it involves mainly the parietal pleura. Here, the pleural thickening involves the visceral pleura. It develops either by the confluence of the pleural plaques or due to the extension of the subpleural fibrosis or due to the fibrotic dissolution of a benign pleural effusion. The patients remain mostly asymptomatic and usually they are seen for other signs and symptoms. There is no specific therapy for this disorder. Third variety is rounded atelectasis, or rounded collapse of the lung. It's a rare complication. Here, due to the scarring of the visceral and parietal pleura, the adjacent lung is encased, is folded because of the pleural reaction or itself. It appears like round atelectasis. Coming to the malignancies, malignant mesothelioma. Malignant mesothelioma is highly associated with asbestos exposure, 80%, and the latency period can be as long as 40 years. Unlike in asbestosis, it's not associated with smoking and it tends to be rapidly fatal. The other bronchogenic carcinomas are lung cancers, or they appear besides smoking tobacco. Asbestos exposure has been linked to the increased incidence of lung cancer. Most common type is adenocarcinoma. We have studied about this in the last class. The parenchymal defect with the asbestos exposure is asbestosis. Here, there will be interstitial pneumonitis and fibrosis, which is caused by the exposure to the asbestos filters, asbestos fibers, and the accumulation of the macrophage is a prominent feature in the cellularity. The prevalence of parenchymal asbestosis among asbestos workers depends on the length of employment. If the length of employment increases, the chances of getting parenchymal asbestosis is high. Depending on the duration and intensity of the exposure, the latency period for the development of the symptoms because of the exposure to asbestos varies from 1 decade to 2 or 3 decades. And the presenting complaints will be dyspnea and cough. On auscultation, you can listen to fine crackles which are present bilaterally in the late and pan-inspiratory phase, heard best at the posterior lung bases, that is the basis of the lung. Posteriorly, you can listen to these fine inspiratory crackles. On chest X-ray, there will be bilateral diffuse reticulonodular opacities. CT scan thorax shows a curvilinear subpleural line and increased interlobular septa. The opacities that are present in dependent areas of the lung, parenchymal bands, and interlobular core structures. Finally, there will be destruction of the lung parenchyma forming honeycombing. The diagnosis of asbestosis is based on the presence of symptoms along with a proper prolonged history of exposure to asbestos. Here, the duration, the onset of the symptoms, type of asbestos, and intensity of the exposure all are important. To investigate, chest X-ray and CT scan are highly useful, and to know the patient's pulmonary function, a spirometry or the pulmonary function test is needed. Some patients require fiber optic bronchoscopic evaluation, wherein a biopsy will be taken from the suspected mass lesion as well as the bronchoalveolar lavage. The fluid which is aspirated from the alveoli is taken, and this can show the presence of coated asbestos fibers. If these fibers are present, these are known as asbestos bodies. The presence of more than one coated fiber has been cited as a necessary criterion for the pathological diagnosis of asbestosis. Till date, there is no established treatment available for this disease. Only regular medical surveillance is recommended because of the high risk of getting lung cancer and mesothelioma. Coming to the last variety of occupational lung disease, it is Byssinosis or brown lung disease, where the exposure is to the organic dust. It is caused by the inhalation of cotton, flax, or hemp dust. It is not immune related, so its sensitization is not needed. There can be early stage where there will be chest tightness which appears occasionally. In the late stage, there will be regular chest tightness. This happens to be at the end of the first day of the work week, that is on Monday. Of Monday evening, the patient will be having dyspnea. That sickness is known as Monday sickness, and it slowly increases to include all the other diseases, all the other days of the week. Treatment for this disease is early on. The treatment is focused on reversing the obstructive disease with using antihistamines and bronchodilators. Finally, removal of the cough is important. Coming to the second variety of lung disease we are discussing now is pulmonary fibrosis. It comes under a broad spectrum, the idiopathic interstitial pneumonias, wherein the idiopathic pulmonary fibrosis and rheumatoid lung will be coming. Classifying the idiopathic interstitial pneumonia, there are 7 varieties of them. The clinical diagnosis in one condition, which we are now going to study, is the idiopathic pulmonary fibrosis. Pathologically, there will be usual interstitial pneumonia, UIP. Second variety is disclamative interstitial pneumonia, DIP. Then there might be respiratory bronchitis, interstitial lung disease, RBILD. There can be acute interstitial pneumonias known as Hammond syndrome, wherein there will be diffuse alveolar damage. And NSIP is a non-specific interstitial pneumonia, which occurs commonly. There will be cryptogenic organizing pneumonia, OP, and lymphoid interstitial pneumonia, LIP. Coming to the idiopathic pulmonary fibrosis, it's the most common type of idiopathic interstitial pneumonias. Once this disease has started, it remains progressive and it is very fatal. The mean onset of this disease occurs in persons who already crossed their 60s, and male to female ratio is 2:1. About the pathology of this IPF, it comes under UIP, usual interstitial pneumonia. Here, there be heterogeneous distribution, that is, when the slide is showing normal lung in one direction, the adjacent part will be occupying bronchglass opacities or reticular nodules and honeycombing. These are all the fibrotic changes that occur in UIP. The histological findings of UIP is also seen in other lung diseases known as diffuse parenchymal lung diseases. About the clinical features of this disease, the IPF, idiopathic pulmonary fibrosis, the onset is insidious. It occurs in elderly people who are crossed their 60s, and the dyspnea remains progressive, and the cough is usually dry without producing any sputum. On auscultation, there will be bilateral, basal, and inspiratory crackles. These crackles are known as Velcro rails. Remember this name, Velcro. Coming to the investigation, the pulmonary function test is parametric evaluation. It shows that the FEM by FVC ratio, the forced expiratory volume in the first second by forced vital capacity, the ratio should be more than 70%. And there will be reduction in the forced vital capacity to less than 80% of predicted. The blood tests are done to exclude other connective tissue disorders or autoimmune disorders like autoimmune disorders. For this, rheumatoid factor and anti-nuclear antibodies have to be, the blood tests have to be done. The chest X-ray shows small lung volume with a basal reticulations. HRCT scan show a basal subpleural reticulation with a traction bronchiectasis, and there will be honeycombing. All these defects will be subpleural and in the basal zones of the lung. Bronchoscopically, if the bronchoalveolar lavage is done, it is done to exclude the infection or malignancy in diagnosing the disease. If the number of neutrophils is more than 3%, it suggests that the patient is having idiopathic pulmonary fibrosis. But if the mass shows, the lavage fluid shows the lymphocytes are high in number, This suggests hypersensitivity pneumonitis, and histologic confirmation can be obtained by doing a thoracoscopy, VATS, or surgical open lung biopsy. Coming to the treatment, for the past century, the IPF is being treated by using prednisolone, a steroid, as well as the N-acetylcysteine, a mucolytic drug. In the past decade, there is a complete change in the treatment aspect wherein the antifibrotic drugs like pirfenidone, which is a novel antifibrotic drug that slows down the reduction in the forced vital capacity of the patient, is being used worldwide. In India also, it's available. Second one is nintedanib, which is an intracellular tyrosine kinase inhibitor. It is used in the Western countries. In patients who are having acute life-threatening disease, IV methylprednisolone is useful. Coming to the rheumatoid disease, the clinical features of rheumatoid disease will be similar to that of idiopathic pulmonary fibrosis, IPF. Here, we have to remember always the Kaplan syndrome, which we discussed previously. The combination of rheumatoid arthritis and occupational lung disease. It can be cold workers, silicosis, or asbestosis. This combination is known as Kaplan syndrome. The other pulmonary features of rheumatoid disease are pleural effusion, rheumatoid nodules, obliterative bronchitis, and cricoarytenoid joint involvement. With this, we completed today's discussion on occupational lung disease. There are other occupations like farmer's lung, which comes under hypersensitivity pneumonitis. We'll discuss about this later. Thank you. I am open for discussion. If there are any questions, try to put them. Okay, if there are no questions, we'll meet again in the next class. All the best. Dear student, if any one of you got any questions, try to put them in the chat box. We'll discuss. Any questions, I'm ready to answer. Friends, if there are no questions, I'll stop the present session. As I hinted you, try to go to your rooms and revise this topic in your standard textbooks. Once you revise it as early as possible, the data, the information will be present in your long-term memory. That is, the information will be present for a longer time and you will benefit from that. Try to do that. All the best.